Well, I'm going to talk to you today. And first of all, I would just say what Fiona said. Warren's presentation was brilliant. So I think mine might seem a little bit more basic, but hopefully you'll be able to follow it. And the overall report on this conference will be available in the ME Society magazine meeting place. I attended this conference with my daughter Sarah, who's a GP in Rotorua, and we've written it up between us. We weren't able to go to New York, unfortunately, obviously partly because of COVID and partly because most of it was done online anyway. But it was the conference, the IAC, which is the International Association for Chronic Fatigue Syndrome, have usually every second year, but they actually had it a year after the last one. And I think that's partly because of all the build-up of research associated with long COVID. Anyway, of course, because it was in New York, it was nighttime for us. So Sarah and I had 4.5 nights of being up, trying desperately to keep awake and keep with it. And we did manage pretty well between us, I think. But you can imagine it's quite an effort. But anyway, we thoroughly enjoyed it. And I'm going to try and go through with you some of the important research. Now, if you can imagine, it was over 4.5 days or nights, and so there were probably about 150 presentations. I didn't actually count, but around that number, and a lot of posters which get put up at these conferences where people are not necessarily wanting to present live. So to pick out from all that lot the things that I would have thought would be most interesting or standing out was quite hard. So probably there are a lot of gaps, but I'll try and go through fairly quickly what was worthwhile. So we had day one were workshops whereby you don't have formal presentations, but you choose which ones you want to go to, and you sit round in groups of quite large groups and discuss a particular topic with some presenters to guide you. And then the next 3.5 days, were the actual presentations by the various speakers with slides. So that first day, Sarah and I attended Caring for Long COVID and Dysautonomia, which is the other name for POTS, which is postural orthostatic tachycardia syndrome, where one feels very woozy, lightheaded if one gets up suddenly or stands for a length of time in the heat. Very typical set of symptoms in chronic fatigue syndrome and other illnesses too. So we chose B and D and enjoyed the presentations which guided us through these particular things. Now I'm going to just try and put something off the screen there, that's better. So I attended particularly and wrote up the Caring for Long COVID workshop, and these people were presenting the work that they had come up with after enrolling 300 patients who had long COVID. The conference, by the way, was a combination of ME, CFS and long COVID, and everyone was acknowledging wide overlap. The long COVID patients, however, they found that 50% of them had what's called comorbidities. This means they have other things wrong with them as well as long COVID or post-viral syndrome, whatever you like to call it. These were people who maybe were suffering from other illnesses as well, like diabetes or high blood pressure or chest complaints. 50% of them were currently probably obese. They had what we call a high BMI. More women than men, as with chronic fatigue syndrome, and many of them had symptoms still at 6 months. The immune system was described by a number of people as being quite haywire. And as Warren has already mentioned, the micro blood clots were found, and I'll talk a little bit more about that later on. And there was evidence of viral persistence in many of these patients. And at this stage, which was a little while ago now, I mean, we're talking of this conference in July, and so probably that related to work that was being done 6 months before that, so nearly a year ago now. But 10% of the long COVID patients did fit the diagnosis for ME/CFS, according to the current criteria used. Caring for long COVID was, again, a lot very similar to what we recommend for chronic fatigue syndrome, to pace very, very carefully from the beginning of the illness. And this is something that should be publicised now, even now, because many people are still going down with this illness and are not aware of the importance of pacing carefully. And that means not overdoing things while you are still quite unwell. Some people were not necessarily terribly unwell at the beginning, so tended to want to go back to work and sport and things like that far too quickly. But, you know, recommending right from the word go to give in as much as possible and not push oneself hard. Symptoms were very much the same as with ME. Fatigue, post-exertional malaise, brain fog, and the dysautonomia in 50%. Sarah actually has done a presentation on that, which at some point you might be able to see. There's a need for education of GPs. This came out again and again for both ME and long COVID. Most GPs were floundering, that they had studied, not really knowing what this was all about, not knowing what to do. And the presentations that Fiona mentioned just now to New Zealand doctors and nurses recently will be a great help to many of them, I'm sure. They also have found that support groups play a really important role. People do feel very, very isolated, particularly having an illness that as yet nobody knows much about, and there's no set treatment plan or cure. So being in a support group, at least one made one feel less isolated and less peculiar. People describe themselves as feeling peculiar when they describe it to friends or family. Nobody really quite grasps this. It wasn't quite like pneumonia or diabetes or appendicitis, something kind of unknown. There was a comment also in some of the presentations that about 2% of the population of the UK at the time of these studies were getting long COVID. So it was quite a large percentage of people that are going to be needing the kind of recognition and help that we are now becoming very aware of. First day, there was a keynote address, the first day of the presentations. This was by David Systrom. He's a pulmonologist, which is a lung specialist from Harvard, and he was particularly involved in this because with long COVID, there is so much problem with lung breathlessness and what have you. He mentioned, I mean, it was a very long address, so I can't go into a lot of detail, but he mentioned there was possibly reduced cardiac output. In other words, the heart wasn't pushing out enough oxygen. And this was perhaps due to the veins flowing back into the heart, not constricting properly, so the flow of blood back into the heart was very slow and low. And as a result of this also, oxygen may not have been getting to the muscles as effectively as it ought to be. And that might be causing problems with the mitochondria, the muscles cells, which are very involved in activity and energy. And he talked a little bit about small fibre neuropathy being involved too. They found that so-called pro-inflammatory cytokines, which are the immune system chemicals that create many symptoms when fighting infection. And these cytokines are activated with exercise in people with this illness, and this may cause mitochondrial damage. And so this may explain why there is the drop-off in energy if you do one test and then have another one 24 or 48 hours later. You just cannot perform as well as you would hope. And this is one of probably the most key symptom in both chronic fatigue syndrome and long COVID. There was just a mention too, and I'll put it in here for interest's sake, that there is a drug called mestinon, which is used to treat another neurological disease called myasthenia gravis. And mestinon is used quite successfully in that neurological illness, and it has been now used in long COVID, and I've used it in the past a lot in ME, and it does help improve some of the symptoms of the illness, the symptoms particularly of the orthostatic intolerance, and improves the opportunity to do more exercise. The other keynote address was by a Japanese lady who is now an American working at Yale, and she has studied long COVID patients who'd been sick for a year. She found that there was a very high monocyte count in many of them. Monocytes are white cells that fight certain infections, and particularly they fight glandular fever. And that group of herpes viruses. And she found that there were high monocyte counts. The T cells and the other various cells that work on killing infection were also worn out or exhausted. She was finding high levels of coronavirus antibodies even a year down the track in some patients, showing that the infection was still active. And there were high levels to Epstein-Barr virus, which is the glandular fever virus, chickenpox virus, varicella, and it's thought that maybe, as I think Warren mentioned, these viruses have been reactivated by the COVID infection. But the interesting thing she did find was in many of the patients, there were low levels of the hormone cortisol. And she looked on this as almost being a likely predictive marker or level of severity of the illness. Now, cortisol has always been mentioned in the past, and whether we should be giving our ME patients cortisol generally hasn't been very successful. And this is probably because the cortisol stimulating hormone, ACTH, is actually normal. So it doesn't seem to matter how much cortisol you give, it doesn't necessarily help with the symptoms. There were also mention of autoantibodies that might be causing this. This HPA axis is the route whereby the cortisol production is stimulated. And these findings fit with both ME and overtraining syndrome, which this particular researcher, Akiko, was going to be looking into. We then had quite a long session on what we call provocation maneuvers, and this all related to the dysautonomia. And this was a panel of experts, which included people like Peter Rowe from North America, who is considered one of the leading world experts in this sort of thing. And the whole session of these people related to provoking and bringing on the symptoms, to bring on symptoms and see what was happening when you brought on the symptoms. So, you know, these were patients who were very brave, really, volunteering for these particular tests. And they found that in general terms, the post-exertional malaise, which is, of course, one of the principal symptoms brought on, patients generally did have a very long recovery. And these were all levels of illness, through from very minor people with minor illness through to quite severe illness. But the recovery was very long from the actual event of provocation. And during that provocation, there was reduced brain flow, leading to what we call cognitive decline, which was sluggish brain thinking, what most patients would describe as brain fog. They found, in general terms, the most reliable test for dealing with looking at the dysautonomia and diagnosing it correctly was the so-called Nassaline test, which you can find quite readily on the internet, and it's useful it can be used in a GP setting because it doesn't need any special equipment like the tilt table, which has traditionally been the diagnostic test for this. The GP can do it. It takes about 15 minutes to prepare the patient for it, and then a longish time afterwards of repeated blood pressure monitoring. So it's not something that's easy for the GP to fit into the busy schedule, but no doubt practice nurses could be trained to do this. Throughout the provocations of these various people's testing, many blood and urine samples were taken to give molecular evidence of what might be going on, and various brain scans and neurocognitive testing was done to see what was actually happening in the brain following provoking the symptoms or bringing them on. One of the things that stood out as being very, very regularly discovered was that hand grip strength, and they do have special machines to do this, so it's not something you can easily do yourself unless you belong to one of these very high-powered gyms, but hand grip strength was generally found to be frequently very, very poor and related to severity of disease. So there's a kind of general weakness that developed. They found for these patients who had so valiantly volunteered, a litre of normal saline given intravenously did speed up recovery. Also was mentioned how hard any of these tests would be to do on young children who would find them quite sort of unappealing and quite scary. Then we moved on to what we call metabolomics, which Warren has alluded to a lot, obviously, and this is the body chemistry, which was looked on by various people doing presentations. There was certainly abnormalities there that seemed to lead to elevation of the pro-inflammatory cytokines before the illness started. Now, this was quite a unique study by Leonard Jason, who's a very well-known epidemiologist in Chicago, and he had selected quite large numbers of teenagers who were well, who hadn't had glandular fever, and he did a whole host of tests on these kids. And then those that developed glandular fever were followed up and found, some of them, of course, to have a post-viral syndrome leading into ME. And in those people, he had found that the urinary metabolites were quite abnormal before they ever got the glandular fever. And you could predict who was going to lead into eventual chronic fatigue syndrome. And, you know, he found that this was really, really important research. I mean, not a lot of people will be having access to this very elaborate testing, but certainly it was found to be very, very important in the overall looking at what happens. And as Warren said earlier, is it genetically inherited, this tendency to have abnormalities even before you ever got sick? Immunology was covered endlessly, inevitably, and there were certainly a number of similar findings in both CFS and in long COVID, and also the CD8 cells, which are a type of white cell in your blood, were found to be similar in glandular fever and in long COVID. And the symptoms, of course, of ME have generally been found in pretty well all the studies to be very, very similar. I just put this issue about the drug Inspiritol in because it's of interest. People with this illness always want to know, well, what's the latest? Is there a drug that can fix me? And this is something that has been used with some success overseas. It's an antioxidant. It's a nasal spray, and it's hugely expensive, which probably explains why it isn't available in New Zealand, or it certainly wasn't at the time of this conference. But I put it in there because it came up in the immunology presentations. This was a study of one patient study of a cadaver, someone who had died, again in the immunology area, and they had examined 6 areas of the brain and found evidence of what we call enteroviral infection in the brain. This was a patient who had classic ME, chronic fatigue syndrome, or long COVID, perhaps we should say. It was a long COVID patient who seemed to fit both diagnoses quite readily. They found that the genes were upregulated, and many of the neurons in this brain were undergoing apoptosis, which was dying sooner than they should have been. And this may be one of the explanations why there were so many debilitating neurological symptoms. I should point out, of course, that even if neurons are dying, this is not abnormal. Our cells live and die all the time, and we do replace them. And this was, of course, in a cadaver anyway, but they were showing signs of varying levels of decline. This was interesting in that it was a talk between a discussion about the monocytes, which are between various immunologists, and finding that monocytes, which are the cells, the white cells produced in glandular fever, were moving into the tissues and sparking inflammation. The monocytes were not entirely healthy, and they correlated with fatigue. So this was all found. The Cornell University group, led by Maureen Hanson, have been very prominent in ME research for a long time. They've also found confirmation in their studies that the platelets, which relate to blood clotting, send out signals that begin a coagulation cascade, and this may well be one of the reasons for the blood clots that have already been mentioned today. And the mechanism was found to be quite different between males and females. Don't ask me to explain it because I'm not an immunologist, so this is all way above my head, but they had found very different mechanisms. And again, this may well explain why the numbers of males and females are different. There are many, many more women who have this illness. I moved on to treatments here because everyone wants to know about treatments, I'm sure, but of course, many of the treatments are not easily available either in a regular doctor's office or even in certain countries. And this one is way out of my area of expertise. The stellate ganglion is a neurological structure in the back of the neck around the nearby the vertebral artery, which is an artery that goes up into the brain. And the stellate ganglion helps control some of the cranial nerves, which control things like smell and taste and vision and hearing and so on. The stellate ganglion block, they're putting local anaesthetic into this area around the back of your neck, which, you know, it's kind of quite a tricky procedure. It's not something that anyone other than an extremely skilled operator would even contemplate. But what they found was it sort of helped improve the brain blood flow, which of course is one of the many symptoms that we hear about frequently in both ME and long COVID. So it seemed a kind of useful opportunity to try these things out, but certainly not something that would be readily available, and not many people around who would even be willing to tackle what could be potentially quite a dangerous maneuver. On the other hand, you know, the patients who'd had it done were extremely grateful and felt a whole lot better. Another man from Liu from the USA found that daily treatment was more effective than the one-off opportunity. But of course, you know, then you're looking at a daily, quite provocative procedure, really. But everyone agreed on this particular panel that it did warrant investigation, and maybe there are other ways of improving the brain blood flow that this can lead on to. There's a man called John Trier in Los Angeles who over the years has been particularly interested in enterovirus infection. This is not obviously a common virus that we've identified frequently. Most people with ME here will, if they've had a virus, it will have been something like glandular fever or flu, or maybe a herpes infection or something like that. That's partly because the enterovirus tends to live in the gut and is not easily found. But John Trier has almost made it his life's work. And he, of course, now has been seeing COVID-19 patients as well. And he did this particular study looking at people who had been diagnosed previously in his earlier studies with enterovirus and now had COVID on top of it. And he looked at this particular group of patients. 37 of them, just over half, had mild symptoms. 17 were quite seriously affected and bedridden, and 8 were hospitalized. And he treated the hospitalized patients with an antiviral agent called remdesivir and dexamethasone, which is a steroid. And 5 of them showed not just marked improvement in their COVID infection, but afterwards their ME symptoms had improved quite a lot with the remdesivir and dexamethasone combination. There seemed to be a link to the treatment rather than just rest. The treatment focused on those who had enteroviral infection in the lead up to their ME CFS. So of course it may not apply to all ME patients. It may well be that it would only be those with the enterovirus, and ME patients who hadn't started their illness with that may well not get the benefit. But remdesivir, however, is the drug that is being used here in New Zealand to treat COVID patients. There were interesting presentations then on public health. Public health being things like how we deal with people in group situations, or how different clinics deal with people beyond just medical treatment. And there were some very interesting presentations from Canada. This particular first one involved health professionals like doctors, nurses, patients, and caregivers. And they gathered fairly large numbers together in groups and shared the stories of how the different individuals viewed the illness or dealt with the illness. And they were all learning from each other. And the health professionals felt it was extremely valuable for them to learn directly from groups of patients with real experiences. And this gave them much better insight into how best to care for these patients. On the opposite side of the coin, the patients and caregivers learned a lot about the doctors and the nurses who knew so little about the illness, because they were bombarded, as we all have been over the years, with having to deal with far more common and treatable illnesses. Another group looked a lot at school. This was again in Canada, school nurses, who are a real key part of the paediatric team when it comes to young children and young adults with chronic fatigue syndrome. And this particular study was quite interesting because they looked not at people who had a definite diagnosis, but kids who were off school a lot. Now, I mean, we hear all the time here about kids who are off school, they're just playing hooky, but these were, you know, kind of more formal studies of why some children seem to be off sick more often than other children, off sick as opposed to truancy. And they found that the kids who were off sick a lot, it was a real risk indicator for a diagnosis of ME, chronic fatigue syndrome. And these people had maybe not ever been diagnosed, it had never come up. But it was found that as a result of searching in this way for absenteeism, that the nurses in the schools could be very much more then involved in helping these kids cope with the illness, or helping with coping with their education, maybe at home. This was large numbers of school nurses were gathered, and it was a big study, but most of the nurses had never heard of ME/CFS. And this again surprises us who are so involved with it. But I think this is the reality out there in the big wide world. Unless you've had, as a medical person, a patient with it, or a relative with it, or a friend with it, you don't really know much about it at all. And it's a big, big issue to have to learn about. And these nurses all were keen to learn more, and it was going to, I think, be spread around Canada to try and educate school nurses. So that's the sort of thing public health is about. Again, in this whole arena of diagnosis and public health, another Canadian presentation had looked at 164 patients, again, high percentage of females, and these were people who had self-diagnosed. And this unfortunately happens a lot, probably again because of lack of doctors having education in the illness, or even the time to spend with the patients. So patients often do tend to self-diagnose, and the social media is the way they do it, of course. Get together in groups and learn from each other about their particular illness. But in fact, when they looked at these people who had self-diagnosed, only a quarter of them actually did fit the diagnosis for ME, even though they thought they had got it. So the conclusion was that self-report is not reliable, and medical staff, which could well be practice nurses, doesn't have to be doctors, they do need training to encourage accurate diagnosis and using some of the well-used, well-researched diagnostic criteria to do those diagnoses. One of the interesting ones that came again from Leonard Jason, the epidemiologist from Chicago, he has produced a very short form which can assess a patient in 5 minutes. Now that may seem a little bit the opposite of what we normally do, because I can remember using the Canadian criteria, for example, which is probably among the most accurate diagnosis form, taking a good half hour. But this one of Jason's is nothing like as detailed, but it just points out the most important factors in trying to make the diagnosis. So it gives you a key. Yes, this patient may have chronic fatigue syndrome, this particular questionnaire indicates that we should now go ahead and just really look and see if this is likely with a more detailed questionnaire. I also found in one of the studies that long-term symptoms of fatigue post-COVID are not necessarily associated with the severity of the infection itself. So you can be pretty ill with COVID, but not get long COVID, but you could have quite a minor infection and get long COVID. And they found the correlations were more related with age and the so-called comorbidities, which are the other illnesses that you might also already have. So the older the person, the more at risk they were of post-COVID, and the other illnesses that they might already have, or obesity particularly was a big factor in leading to long COVID. So this all needs to be looked at very thoroughly. So that's how Sarah and I felt at the end of 4.5 nights up, trying to get through all these presentations. We managed to stay awake for most of them. The brain is still scrambled. I imagine Warren's often feels the same. But anyway, hopefully I've given you some food for thought, and if you want more detail, then ANZMES will have the magazine write-up of the whole conference. Thank you.
Great, thank you, Ros. It was a very thorough update on the research, and we do appreciate your and Sarah's commitment to staying up all night throughout the night, especially as I know Sarah had to work in the clinic as well during the day. So thank you to you both. And are there any questions for Ros? We've got a comment that said that Wendy found that a litre of normal saline helped with her recovery in the past. And someone said, wow, 4 nights. Thank you for your efforts, Dr. V. Thank you for your presentation. Very interesting. Claire said, thank you, Ros. So glad you can take out some of the information in small bites that we can follow. Thank you, Ros. Lots of interesting info. Love the scrambled brain. Thank you. Thank you so much, Dr. Vallings, for attending and passing on the info.
I think the scrambled brain one could go side by side with Warren's jigsaw.
Yeah, absolutely. We do have a question for Warren. What does Dr. Tate recommend to do to help energy production and protect against oxidative stress? And Ros, you might be able to answer some of that as well.
On the chat, I tried to just respond to suggest that the person sends me an email, and because it's quite a comprehensive answer, you know, in our the second publication I mentioned in the European Association of Medicine, we went into the therapeutic possibilities for oxidative stress, and there are a number of possibilities. Things like, coenzyme Q linked to selenium, which is important for a glutathione peroxidase, which is that in combination seems to be quite good. But there are some other, apart from coenzyme Q and mita-Q and N-acetyl cysteine, which are used, you know, which I think have got benefits, but it would be good if we could have clinical trials to show much more definitive data. There's some other less well-known drugs which look as though, you know, they could be quite useful, but these would be more carefully prescribed through health practitioners, not things you would actually just go and buy, you know, from your local pharmacy, as we can do with coenzyme Q, mita-Q. So I've got quite a reasoned part of that manuscript I wrote and published that I'm happy to provide for people, which would be kind of a better way than if I just talked on for another 10 minutes, as it were, if that's okay.
No, that's fine. Thank you, Warren. Ros, was there anything you wanted to add to that to help with energy production?
No, I think when I was doing the surgery, I had quite a lot of patients on CoQ10 and MitoQ, and I would say probably about a third or even a half of them would have noticed some benefit. But the worst aspect of it, of course, the major side effect is the cost. Yeah. Some people, have no problem affording it, but it is quite expensive.
Yeah, absolutely. And I think you found that it didn't always help everybody. So it was about a third it helped.
I think that's the story with ME generally, and I'm talking ME now, not long COVID, but generally with ME, whatever you try, not everyone benefits. And I think, we're obviously sometimes looking at subcategories of the same illness. And for example, some people will say they get a lot of side effects from something and they don't want to carry on. Some people will say it didn't help me at all. And others will say, well, that was just wonderful. So, you are looking at different body types and different background illnesses and other things that are going on, and maybe different strains of the same illness.
Absolutely. I think that's why it's important that Warren alluded to, is that we need to start studying individuals. That right, Warren?
Yeah, certainly. I mean, I'm convinced that now, the more we individualize the patient studies, it's amazing how, even with the relapse recovery study, the individual bases on the DNA that change were different between the two patients, even though at the end, the overall dysfunctional physiology was the same. So you can have different molecular changes leading to the same endpoint. That might mean if you target something, you might be targeting the wrong thing with some patients and not with others. Can I also say about the MitoQ? We did a patient study with MitoQ, and we could show actually an improvement in their energy production function. But unfortunately, the patient said, I didn't really feel any better. So, even though scientifically I was really excited by this MitoQ, and MitoQ has got really good theoretical scientific basis to say why it might be very useful. But if the patient doesn't feel any better, no matter how excited I am about the results of the study, it's not.
Yeah, exactly. And that's what you want. You want it to be both, don't you? Actually seeing that it works and then having that knock-on effect for the patient. Yeah. There was a comment. Oh, thank you, Ros, for the interesting talk and for your work. I'm reading your book at the moment. That was from Rachel. Wendy has her hand up, so I think she has a question for one of you or a comment.
I had a question for Ros. The bit you were talking about the injections into the base of the brain there, that increased the blood flow. I just wondered, because two people I've spoken to, one found that just by putting one of those very cold packs, wrapping a bandana around her head with a cold pack in the back, seemed to reduce a lot of confusion, brain confusion and things. And another person I talked to actually rubbed an anti-inflammatory into the base of their neck there too at times, and it seemed to produce the same result. So would that be doing the same thing as those injections, or along the similar lines?
Well, I'm not a neurologist, so I wouldn't give an absolute yes/no answer to that. But I think individual patients' reactions to things are always worth listening to. And I can think back maybe 30 years now when I first started getting involved in this illness, that I had one patient who used to spend some time standing on her head in a corner because she got this improved brain blood flow. And if she sort of came back to the sort of sitting position very slowly, she maintained the improved brain blood flow for quite a few times, maybe 30 minutes. And I mean, it sounds quite bizarre now, doesn't it? We're not going to get our patients standing on their heads in the corner. But, that at the time was considered quite a useful thing to learn about. And so, we should listen to our patients for sure.
Thanks, Ros.
Thank you. Are there any other questions? Dr. Ros, I was diagnosed by you 5 years ago. Would you recommend anything different to treatment or management for ME now?
Well, it's hard to know because, I'm not going to go into your particular case and know what treatment you might have had, but I think we're still looking at the very basic kind of treatment for most people, which is attention to, avoidance of too much exercise, extreme care with avoiding foods that may upset or cause any allergy problems, stress management for sure, and maintaining or aiming for a really good sleep. Sleep does seem to be the key for many people at helping to alleviate a lot of their symptoms, particularly pain. So the basic sort of core treatment plan is much the same, but I suppose now we are gradually fine-tuning it to all the new research coming out, helping us, giving us some new ideas.
That's great, thank you. Great, okay, so it doesn't look like we have any other questions. Is there anything, Warren or Ros, that you just want to touch on before we finish?
Well, I'd like to thank you, Fiona, for having us here and running a really efficient, good meeting.
Oh, thank you, Ros.
Yeah, I mean, it's a real privilege to me every time I actually, talk to an ANZMES group or an ME group. And so quite uplifting, and I get some inspiration from listening to not only the questions and patient experiences, but also hearing Ros talk. So, it's very beneficial for me. So thanks, Fiona.
Yeah, and I learn a lot from Warren. He's my, he saves me getting the textbooks and reading all the papers that might be there that might be useful. I can always rely on Warren.
Absolutely, I think we all benefit from each other, don't we? Being able to just talk about things and run ideas past each other. So it's wonderful to have this network and community of people and just amazing experts like yourselves, Ros and Warren. So thank you so much. So it doesn't look like there's any more questions. So I think we'll finish off there, and just to thank everybody who has been in attendance today, and a reminder that the recordings will be up on our YouTube channel in the next few days for you to go and listen to again. So thank you, everybody, and enjoy the rest of your weekend.
Thanks.
Take care.